So really there are so many applications to the AddOn IOL, and the first part of this talk will be how and why we use it, and then the second part will be running through some case studies, which I think is the best way to showcase this lens. And it's not just for vision upgrade, but also for reversibility. So I'll go through some things in relation to that. So I just really want to start, I don't know how familiar you are with the lens, so I just really wanted to start with a video showing the implantation of the lens. So you can see there's a little bit of capsular fibrosis here. This is a secondary AddOn IOL implantation. This is a patient that just had a residual refractive error, had an EDOF of a different platform in both eyes, and had had their surgery done elsewhere but wasn't happy with the reading vision. So she tolerated mini monovision very well. So one of the things you'll get to do today is practice loading the lenses, and I think it's really important to, there is a bit of a learning curve with that, but really the main tip I have for you is be careful with the haptics. Make sure that you tuck them underneath the little flange. And usually I do load this lens myself. There are some surgeons that load all their lenses. I don't load my other in the bag lenses, but this lens I load because the haptics are crucial to get right, and it's not hard to get it right. So here we see the implantation. It goes into the sulcus, so I deliver it to the anterior chamber. Sometimes you're lucky and some of the haptics go straight into the sulcus. And what I've done for this patient here is just put a +1 in this eye, and it's given her some mini monovision over the top of an existing EDOF to give her some mini monovision. She's very happy. So I just wanted to start with that to show you what I'm actually talking about. So worldwide, there are 10 million cataract surgeries performed each year, and only 500,000 are implanted with a premium lens. So that would be an EDOF, a trifocal, or a toric. So 9.5 million are implanted with monofocals. That's huge. That means that 5.7 million of those implantations still feel that they're out of their visual comfort zone. So we can do better than that. And I presented, on the next slide I'll show, but you know, we get to do a lot of cataract surgeries. I love time-lapse videos, so I wanted to include this. And you know, the operating theatre really is my happy place. So we're, you know, and just demonstrating, we do a lot of cataract surgeries. That's why we're all here, to learn how to be better. We can always be better every day. So we want to do better for our patients. I wish. So the secondary sulcus AddOn IOL is specifically designed for the sulcus. You know, this is an anterior image, and I hope the resolution is good enough, but you can see that the lens is vaulted in a way away from the primary lens. So we don't have the traditional problems that we've heard about in the legacy times of piggyback lenses. You can use the term piggyback, but it has some bad press from the past with interlenticular fibrosis, and you don't see that with this lens. This is a lens specifically designed for the sulcus when there's already a lens in the bag. So not for phakic eyes, not for PC tears where you can't put a lens in the bag, when there's been successful primary surgery. And this is the option. We have a trifocal. It's a very similar platform actually to the Liberty IOL. So it's got 6 diffractive rings instead of 7, but very few dysphotopsias as a result. And there's a trifocal toric, there's a monofocal toric, and also the Charioth macular lens. So I can't wait to hear Dr. Harvey Ui's experience on the Charioth macular lens, because it has some very novel uses. So just put a bookmark in that place, and we'll talk more about that later. So it has 4 flexible haptics, and they act like springs. So the lens is very accommodating to any kind of sulcus anatomy. Because the optic, the size of the optic, we don't see pupillary capture of the lens. and it has excellent rotational stability. So we know that there are other sulcus lenses available that we've had for a long time. They're not rotationally stable. Do not expect that you'll be correcting astigmatism effectively. They spin. So I spoke about the interlenticular opacification. It's just not a conversation with this lens at all. We don't have to worry about it because there's no contact between the lenticular surfaces, and that's even in cases of high-powered monofocal IOLs where we're up to the 30 diopters and upwards. You just don't see the contact, but you do need to have sufficient anterior chamber depth to implant this lens. And if you're thinking about implanting it as a dual procedure, that means at the time of the cataract surgery, taking the cataract out, putting a lens in the bag, and putting an add-on on top at the one surgery. And you might want to do that for various reasons, and I'll go into that in my case studies, but the most common reason might be to give reversibility to the multifocal portion if the patient's not sure. So I'll talk about that in just a moment. So there are guidelines about either the internal or the external anterior chamber depth in either a phakic or a pseudophakic eye. So that covers all bases where you might want to use the lens. The second thing you need is a subjective refraction if you're doing it as a secondary procedure. So in my country, ophthalmologists, we learn how to refract, but then nobody does it unless you're a refractive surgeon or a pediatric ophthalmologist. So you have to be able to do a subjective refraction or have staff in your rooms whose subjective refraction you trust, because those numbers are what you'll base your calculations on for the lens implant. And then the third thing you need is biometry, either for a phakic or a pseudophakic eye, depending on if it's a dual procedure, 2 lenses at the one time, or a delayed procedure, because the biometry goes into the calculator. I spoke already a little bit about this old group of people that look very different these days, same age, different expectations. And we're still looking for the holy grail of presbyopia correction, where people don't want to wear their reading glasses, and we're getting closer and closer, we're getting better. But part of the job is on us to offer our patients the technology and to use it well. We all know this picture, right? Do we show this picture to our patients? I do, about the halos and glares. And some patients say, I already have this, just fix my vision, I don't mind. And some patients are the other end of the spectrum, I do not want that. But then there's this middle ground of patients that really aren't sure. So I call them yellow flag patients, where there's no particular ocular reason why I wouldn't put in a multifocal IOL. There might be some borderline features, like, oh, they have a little bit of dryness, which is not to be underestimated. Dr. Lee and I have already talked about the ocular surface over and over. But also mostly it can be the personality. The patient just can't decide. And we live in an age where we give our patients more information. We live in an age where we involve them a little bit more in the decision making. They still want us to guide them, but some patients just don't know about the halos and glares. What will that look like? I don't know if I'll like it. I'm not sure. And then there's the patient that, can you take it out if I don't like it? And I don't know about you, but I do let IOL explants if I have to, but I don't love doing it because that's a good cataract surgery that can turn out worse. It's happy when it turns out well, but it's higher stress surgery. So these are the specs. I just really wanted to highlight the 6 diffractive rings, which I had already spoken about. This is not great resolution, but I'm going to read this out because this is my first case. So this is a patient that had an injury to his right eye. He underwent a right vitrectomy, retinal repair for detachment, and cataract surgery. On the left-hand side, there's a developing cataract. So he had his right cataract surgery, and he was referred to me, more than happy to wear reading glasses. He had a monofocal lens in the bag. But he had a degree of myopia and astigmatism, or mixed astigmatism, and this was his subjective refraction when he came to me. And his uncorrected vision in the right eye was 618, and his best corrected was 6/7. 7.5. So does anybody want to speak up and say what else would you like to see here? Or will we have a very quiet audience and I'm going to just show you next, if my clicker works. Could we go to the next slide, please? Could you help me? There we go. So that's the topography. Looks pretty normal. And we can see the anterior chamber depth, 4 point something. So I'm thinking, I'm going to not do laser vision correction on this guy. This is an opportunity on discussion with him. How do you feel about wearing reading glasses? I don't mind, but is there an option where I don't have to wear them? So instead of doing a laser vision correction enhancement to get rid of that script, which is a mixed script, I thought this is a real opportunity to put a multifocal add-on in instead. So that's what I did. I put a multifocal add-on aiming for plano. He was super happy, 7.5 N6. And then I went and put a Liberty in his left eye because he had a developing cataract. And he's one of my most grateful patients. So, you know, we have patients that walk through the door, our heart sinks. This is not one of those. This is one of those patients that walk through the door, we feel happy to see them because they're super happy. So this is just a video also showing in more detail. Just here, you can see this little notch on the lens. You'll see it under the microscope when you practice at the microscope over here on the other side of the room. And this is an orientation little notch on the lens that's in the leading right and trailing left to ensure that you put that lens in the right way up and in the right orientation. Tucking those haptics underneath the flange of that cartridge. There are a couple of different ways you can fold this lens into the cartridge, but I like to have a valley style where I press down on the lens to make sure it doesn't get, and as you close the cartridge you get that nice click so you know the haptic is not caught there. So that's the first application, is a vision upgrade. So the next application that I also did refine his residual refractive error as well, but this next case that I'd like to discuss is refining residual refractive error. And I talked a little bit about why would I not laser that patient, and mainly for him it was because I had a chance to do something more. But dry eye is not to be underestimated. It's becoming much more common in my younger patients even. So we have to start to think about other ways. And the thing I like about the secondary sulcus AddOn IOL is it's accessible to every cataract surgeon. You don't have to have access to a laser suite. You don't have to know how to do a LASIK flap. You don't have to know how to do lenticule surgery. Every single person in this room can do it. So my second case is residual high astigmatism. So a 72-year-old man referred for a second opinion regarding reduced right visual acuity, had a right macular hole repair in 2020 and a right pterygium excision with graft in 2020 by another surgeon, and there's a lot of corneal scarring because of the pterygium removal. It was a large pterygium. So he's had bilateral cataract surgery, and this is what he's wearing in his glasses. 5.25 diopters of SIL, but his subjective refraction actually shows 8 diopters of SIL. What are we going to do? The IOL in the bag is a 6 diopter lens. This surgery was done by another surgeon. So what are we going to do? You know, do we rotate the IOL? I had no information about where that IOL was supposed to be. And to go in and rotate an IOL that's fibrosed, stable in the bag, is higher risk. So you can see the topography here is quite irregular. There's some regular and irregular components. But we know from the subjective refraction that the vision corrects up from 660 to 621. So 621 is the visual potential of the eye. So what's limiting it is maybe the macula, maybe the cornea, it doesn't matter. But based on the subjective refraction, we can do much better. And the keratometry on the pentacam, the IOL master, varies. So based on the subjective refraction, really in this corneal refractive surgery for an 8 diopter astigmatism script is not viable. I really don't want to do an IOL exchange. There's no need. repositioning of the toric IOL, I've got no idea. Mathematically, I'm not clever enough to figure out if rotating that IOL when I don't know the original implant axis, if that's going to do the job. Plus that carries higher risk because you've got to free the lens up to rotate it. So I put in a first Chiu AddOn IOL to correct the residual astigmatism. And I was a little bit worried because he already had a 6 diopter toric lens in the bag. What was it going to be like optically for him to put a big high toric AddOn IOL on top of the IOL in the bag? But things went very well, and he actually got better than what we had predicted from the subjective refraction, which you may recall was 621. He got to 612. So I think in the case where this is not a purely refractive, we're going to get you to 6.6. A toric over a toric in this case worked very well. So then the next case I want to present to you is when the IOL in the bag calculation, so just the biometry, is inconsistent or uncertain. So this is a man, 72-year-old man, best corrected vision 621, got cataracts in both eyes, otherwise healthy exam, just been wearing glasses most of his life. And this is what I found. We'll just talk about his right eye. This is what I found in his glasses. This is what I found on autorefraction. Big difference in the astigmatism. 3.5 diopters in his glasses and nearly 8 diopters on the autorefract. And this is his topography. So you can see here in both eyes, the right and the left eye, this is, you know, a marginal pellucid type picture. And this is why the keratometry is so inconsistent, or the subjective refraction and the autorefraction, I should say. But this is what I saw when I looked at his keratometry and his topography and the subjective refraction. So a big variation between the IOL master keratometry and the pentacam. So I did his primary cataract surgery and put a monofocal non-toric IOL in the bag because I didn't really know what toric lens to put in. It was too inconsistent. And then got a number of subjective refractions post-operatively. I prefer to get 2 stable refractions 2 or more weeks apart. So I start at 4 weeks when things usually are stable for our cataract patients, and based on the subjective refraction, then I put an AddOn toric in the sulcus, and we managed, despite that abnormal cornea, to get him to 6.6 with very, you know, minimal 0.25 diopters of residual sil. So also another case where the biometry is inconsistent preoperatively is a patient that presented with bilateral cataracts with extensive corneal scarring from a -12 myopic PRK treatment in the 90s. So those laser treatments were different back then. And she had a high amount of myopic regression and also had macular schisis in both eyes with best corrected vision, again of 621. So she had myopic regression to -8, -10. So in this case, we're just going to talk about the left eye. And again, the glasses script was very inconsistent with the subjective refraction. And we decided through our conversation that we were only going to use a monofocal lens because of the corneal scarring, and we were going to aim to keep her myopia but make her about -2. So very abnormal topography with extensive corneal thinning and very flat corneas. So in the left eye, you can see that the astigmatism varies on the IOL master, the eye trace, and in those days I was using an orb scan of 3.4 diopters, 2.4 diopters and 1.8 diopters, and the axis varies 128 to 123 to 142. So what toric lens am I going to put in? So again, I did the primary cataract surgery with a monofocal lens in the bag, got 2 stable refractions greater than 2 weeks apart. We were in the vicinity of the -2 target except for the astigmatic component. and her best corrected vision is not great because of the cornea and the macula. And so I put an AddOn toric IOL in, and again we got her better to what was predicted from the subjective refraction with a -2 target achieved. So she's as happy as she can be with her other ocular issues with the vision, and we've gotten the most out of the vision that we can. It took a long time for her corneas to settle, and I think that that's the case with weird corneas. They can take longer, so you really need to wait until you get those 2 stable refractions, and it may take longer than 4 to 6 weeks. So let's talk about another novel, quite niche application of the AddOn IOL, and that's to protect a hydrophilic IOL that's in the bag. So this is a patient that had a left cataract and DSEC. The endothelial graft failed, and the patient required a redo endothelial graft. And this patient, and the graft was done in 2011, so the patient's done very well with the graft, but the vision dropped to hand movements from a decompensated DSEC graft. The patient had a hydrophilic, I think it was a Zeiss lens actually, in the bag, and with an air bubble during the DSEC case, we worry that a hydrophilic lens may calcify or opacify. And so we put a plano lens, AddOn IOL. Now, mind you, the AddOn is also hydrophilic, but if it opacifies, in this case from the air bubble, it doesn't matter because we can take it out and it preserves that lens in the bag, which having to take that out is a much bigger deal. So to date, this patient has done well post-DSEC, and we've been lucky in this case because actually the AddOn has not had any issues with opacification, but if it does down the track because of that transient air bubble, then we can take it out and that Zeiss lens in the bag is going to be fine. So then let's talk about using 2 lenses at the time of the cataract surgery, which I spoke about a little bit earlier in this presentation. And that's using a multifocal lens at the time of the cataract surgery to give reversibility to the multifocality for the patient who's not sure or maybe has to use some borderline clinical measurements where you think, oh, is a multifocal the right thing for this patient? So this is a 23-year-old woman, very young, and she's got an element of left amblyopia, and her best corrected vision with her high hyperopic script, so +8, is 666/24. She was not suitable for laser vision correction with this kind of hyperopic script. It's extreme. She had an anterior chamber depth of 2.9, so I also do a lot of phakic IOLs, so that's not enough anterior chamber depth. So really her only choice, and this is the eye trace, and what it's showing here is the angle alpha. The angle alpha is high, it's 0.7, 0.63. So that is something that I do look at when I'm choosing my multifocal suitabilities. But she was desperate to do something. She's wearing these thick Coke bottle glasses, can't tolerate contact lenses. So with very careful informed consent, I talked to her about an RLE in a young patient, which I would do in a hyperopic patient. In a myopic patient, different story, no-go zone, because of the risk of retinal detachment. So, and another measure if you've got an IOL master is to look at the Chang-Waring chord as an approximation of angle alpha. So she can't have laser, she can't have a phakic IOL. The only option is RLE, refractive lens exchange, but there are concerns on my part as the surgeon about her suitability for multifocality, but she's young. Do I want her presbyopic from a monofocal lens in the bag? So at this time, you know, really I felt that bilateral surgery, even though she was amblyopic, it would give her better binocular summation. And actually what I find is the amblyopic patients tolerate the halos and glares better than the non-amblyopic patients. And she's got enough anterior chamber depth to support an AddOn IOL. So we went ahead and did 4 lenses in the one day, both eyes. And this is, you can see her primary lens going into the bag. This also is a toric. So you correct everything in the bag that you can, aiming for plano, because if you end up needing to take that multifocal add-on out, you still want her to have good distance vision. So it's important in this case to correct everything you can in the bag. Okay? Then I'm putting viscoelastic into the sulcus. And the only thing I would say really that differs in these cases, in the dual lens approach, doing the 2 lenses in the one eye on the one day, is the primary lens. My tips are get the viscoelastic out of the bag first before you put the add-on in, because getting the viscoelastic out of the bag after the add-on goes in is challenging, and I wouldn't recommend it. And then, again, just showing the loading, I encourage you highly to have a go at it under the microscope today. And then the other thing is because there is a toric in the bag, when you're manipulating the add-on and placing those haptics into the sulcus, you just don't want, you want to watch the rotation of your lens in the bag, which of course is not going to be an issue when you're doing it as a later approach, because that toric IOL will be stable. So really the main issue here, once you remove the viscoelastic from in the bag IOL, of course you put viscoelastic on top of your primary lens and in the sulcus, and it's about getting the viscoelastic out from underneath the add-on. So you've got to do that too. So as you can see, not hard. And I use a coaxial IA, but it would be even easier with a bimanual IA. So this worked very well, and we have not reversed her multifocality. She's done well in both eyes. So the next case I want to discuss with you, and I think it's my last case, is a patient that was referred by her optometrist, a 61-year-old female, with a deterioration in her vision in her left eye. And she's a high myope, -8, -12, who's accustomed to wearing contact lenses in a monovision configuration. She's 61 and presbyopic. So when I saw her when she was referred to me, her left eye had shifted to -20. So, and she was wearing a balance script because she could not tolerate this. So she had mild nuclear sclerosis bilaterally, and importantly in her right eye, the best corrected vision is still 6/6. So I guess nobody's going to answer my questions about what you'd like to see next, so I'll show you. I wanted to see the corneal topography, because was there some ectatic type? She hadn't had laser vision correction, but was there something going on with the cornea to cause that myopic shift? There was not. And, you know, I'm a cataract and refractive surgeon, so I have to look past the lens sometimes, even though I don't like to. And this is what I saw when I did an OCT. So you can see this macular abnormal appearance, and she had developed a staphyloma. And the axial lengths, when I measured them, 27 millimetres in the -8 eye and 30 millimetres in the eye that had progressed to -20. So what I did was, this had obviously happened fairly recently, so I followed her for a while before proposing any intervention, and she couldn't tolerate spectacles or contact lenses because the script was too high. So she ended up being stable over the period of 12 months. So then we went ahead and did her left cataract surgery, but what target was I going to aim for? She was no longer suitable for monovision, because I think Monwai would be able to tell me about retinal macular issues, but I think that there was stretching of the macular fibres from the staphyloma. I don't know, but we decided to aim, you know, should we aim -2 and keep her myopia, because we're doing her cataract surgery, but what was that going to do to the right eye, which is still -8? She was not going to tolerate the anisometropia. I was concerned about that. Did I really want to aim -8 in the left eye? Like, as I said, I'm a refractive surgeon. Do I want to keep somebody -8? My hands were a little bit tied. We decided to aim -8, And the discussion we had was, she was adamant she didn't want her right eye touched at this point. So we decided, let's aim -8, let's balance you out. And when you need your cataract surgery in your right eye, let's aim -2 or 2.5, whatever myopia you want to keep, and we'll put an add-on in this eye and balance her up. So it leaves options open for the future. You can forward plan. It's like an option forward plan for an add-on down the track to change the refractive result. So at this stage, I still see her on a yearly basis, and she's doing well, she's happy. She doesn't have a visually significant cataract yet in her right eye, so she's -8 both eyes. So just to summarise, there are some more standard applications of the AddOn IOL and also some novel and unique applications, but it's great to have it in your toolkit. So we can use it as a single dual lens procedure, the 2 lenses in one day, and that's mainly about the reversibility to the multifocality. It may also be, if there's a possibility of the script or especially the astigmatism changing down the track, so with progressive ectasia, or if the patient may need a future PK, so those abnormal corneas. We can also use it as a secondary delayed procedure, so to refine your refractive outcome, to upgrade the vision, either with a toric or a multifocal IOL, for those weird corneas where the measurements just don't make sense preoperatively and you have no idea what you're going to do and you don't want to close your eyes and stab in the dark. And protection of a hydrophilic lens, if that's in the bag, if there needs to be an air bubble in the anterior chamber, for example, during a DSEK. Sometimes patients also may change their mind down the track. And because most of the implantations around the world are non-presbyopia correcting lenses, this is a perfect, and also I do know some surgeons in my hometown that don't use toric lenses at all in their practice. And so this is a perfect opportunity to improve things down the track, or if patients change their mind. And there will be other, applications as we gain more and more experience. And as I alluded to, I really want to hear from Dr. Harvey about his experience with the Charioth macular lens, which is a magnifying lens, which traditionally was formulated for... Could we go back? Sorry, to my last slide. I went to the last slide. Sorry, I skipped over it. So those are the applications of the add-on. Please practice at the microscope. Please ask any questions.
Thank you. Thank you for the presentation. I would like to ask how to calculate the diopter to use and alignments of toric add-on.
So we do need to have enough space in the anterior chamber, and we need the biometry. The biometry does go into the calculator. So it's mainly based on subjective refraction. You just get your subjective refraction to the target that you want, and that's how you it goes into the calculator. So I'm not sure if I had a slide with the calculator, but I'll try and go back to show. Nikki, can you help me over there? You would know what the calculating page looks like, but can we just bring one of those up? And I'll show you what the calculator looks like, if you have a chance, Nikki. If not. Yeah, so the calculator, your local Medicontur rep, I hand the calculations off. I give my subjective refraction and the biometry, and my Medicontur rep takes care of the rest with the calculations. So there is a calculator, but I don't access it directly online. I give the information to my rep and they do the calculations for me. And they will give me sometimes a couple of options about choosing the final residual refraction, just like choosing a regular IOL.
Thank you.
Dr. Uy.
Yeah. Thanks, Alison, for that very nice presentation. So, yes, I'd like to share our approach using the AddOn Charioth macular lens or SML lens for treating patients with high myopia. I'm a VR surgeon, which means vitreorefractive surgeon. So we started out using the SML lens for patients with advanced macular degeneration to enable them to improve their reading vision. And one day in conversation with Dr. Gabor Charioth, he suggested, why don't you try using it in patients with high myopia? Because patients with high myopia, they like to read like this. If you put in a trifocal lens and you tell them to read like this, they say, I can't see. They want to read like this because they've been doing this for decades.
And also they're reading Chinese characters,
Yes,
which for us in Australia, it didn't automatically occur to me, but they need much better near vision than what we expect.
So the approach that we follow is, so if a patient is highly myopic, let's say -6 and above, then I will have a long conversation, and the non-dominant eye, we will put in a trifocal lens. And if they're happy with the vision with the trifocal lens, then the dominant eye will put in a trifocal lens as well. Because they're happy in the non-dominant eye, most likely they'll be happy in the dominant eye with the same lens. But if they tell us after the first eye that they're not happy, they like to read up close, then the second eye, we will do the procedure in 2 stages. The first stage is we will put in a monofocal lens so that they have good distance vision. And then after a month, when their refraction is stable, we will put in the AddOn SML lens. And that will give them the close, ultra close vision that they're used to, and that makes them happy. We do it in 2 steps because after the first surgery, if there's any residual refractive error, then we can implant the SML lens that also corrects that residual refractive error. That way we wind up with the distance emmetropia in the second eye, and plus they have the vision, the near vision that they're used to all their lives. So that's the approach that we follow.
Yeah, I loved hearing from Dr. Harvey about this approach when we had the chance to collaborate in the lead up to this meeting, to hear that these patients are, 20/20 or 6/6 for the distance, and they have such amazing near vision because of the magnification of the Charioth macular lens, which, as I alluded to, was traditionally designed for dry AMD, stable dry AMD patients. But unlike those patients, the use in this particular application doesn't require the quite intensive patient training because they don't have the macular pathology. But one of the other things that Dr. Harvey imparted as a pearl to me was, it's excellent, because my next question to him was, would you put it in both eyes? And that brought around about a conversation of, it's probably best not to use it monocularly in the patient that requires good stereopsis for near, such as fine tasks up close like sewing or needlework or things like that. But it sounds like a wonderful way to solve that near vision for the high myopes, which we know in the refractive setting, traditionally, unless we give them some myopia in their particular technology that we're using, monofocal, EDOF, trifocal, they never feel like the near vision is good enough. So this is a way to get them very happy with their near vision.
Okay, I think you've got a lot of interest in the add-on. It's something that we are not quite used to hearing. Have you got more?
I don't have more, but thank you very much. This is what the calculator looks like, where you enter the data. You pick the lens that you want, trifocal, spheric, toric, plus minus toric, and whether they're phakic or pseudophakic, you enter their target refraction in order to get the proposal of desired refractive outcome. And so you can just pick the one that grows closest to emmetropia, or if you want to leave a little bit of residual myopia, that's how you do that. So it's very straightforward.
Last question.
Just maybe a comment about the technique. So when we put in these add-on lenses, we routinely constrict the pupil at the end of the surgery.
Yes, I do too, actually. We had a shortage of Myocol in Australia. I don't know if you did too. So one of the cases that I recorded, you didn't see the pupil constricting because I put Myostat in. And, we joke sometimes some things take so long inside the eye, like not these lenses, but some other lenses take so long you can go make a cup of tea while things are happening in the eye. So I just didn't include it in the video. But yeah, I think it's useful to bring the pupil down just to make sure that you don't get any capture of the edge of the optic, because, these eyes usually have a lot of dilation before their cataract surgery. I agree. Thank you for bringing that up.
And then the last point, I also load these lenses myself. All our other lenses, the operating nurse loads it, but this one I load myself because we've had the experience that once in a while the trailing haptic gets stuck between the blue plunger and the wall of the injection cartridge. And sometimes it'll come out even when I load it. There's a break in one of the haptics. But we found that even if you break one of the haptics, you don't have to remove it and replace it. The centration is still excellent. So don't worry if in your first few cases that happens, just leave it there.
That's right. There is a learning curve. It's one of the pearls when learning how to do it, is how to load the lens and make sure that trailing haptic doesn't get caught in the plunger. But again, I agree. I have had a little mishap myself with the trailing haptic, and I've still implanted it, and it's not just well centrated but also still rotationally stable. So it's forgiving in that way.
Okay, thank you, Alison.
Thank
I think we're going to move